Hi everyone, and welcome to our module on local and regional anesthesia. Local anesthetics are drugs that block sodium channels in nerves. Nerves need to conduct sodium in order to send signals back and forth, and so if a nerve becomes impermeable to sodium, then it can't propagate a signal, and that's going to lead to loss of sensation, especially of pain. Local anesthetics generally end in the word cane, like lidocaine or bupivacaine or tetracaine, and they can be broken down into two groups based on their chemical structures. The amides have a nitrogen group like lidocaine shown here, and the esters do not have a nitrogen group. And this really doesn't have any clinical relevance to how the drugs work, but you will hear them referred to as an amide or an ester, so you should be familiar with this breakdown. Local anesthetics display a property called differential blockade, and this refers to the fact that certain types of nerve fibers are affected before others. How easily a nerve fiber has its function blocked by a local anesthetic depends on the diameter of the nerve and also whether it's myelinated or not. Shown on this slide is a table displaying the order in which different types of nerves are blocked. The easiest nerves to block are those of the sympathetic nervous system, and you can see evidence of this clinically if you inject a local anesthetic under the skin. The skin will often become flushed from vasodilation, and that's because you've taken away the vasoconstriction that the sympathetic nervous system normally causes to some degree to the skin. After the sympathetic nervous system, pain is blocked, which makes these drugs useful as anesthetics to take away pain, and then following pain, temperature, pressure, and lastly, motor function will be blocked. The duration of action is different for the different local anesthetics. The drug with the shortest duration of action is procaine. Lidocaine and bupivacaine have a medium duration, and drugs that have the longest duration of action are bupivacaine and tetracaine. And as we'll see later, bupivacaine is very popular for many forms of anesthesia, including spinal anesthesia, and part of the reason it's popular is because it has a longer duration of action and won't quickly wear off. Local anesthetics don't generally have a lot of adverse effects, unless you inject so much that the drug is taken up and begins to circulate throughout the body. This can happen if you accidentally inject a local anesthetic into a blood vessel, or if you give a very high dose that exceeds the maximum recommended dose. When patients have systemic effects from local anesthetics, there is no antidote. The treatment is merely to support the patient until the effects wear off. And the two major systems that are affected with systemic administration of local anesthetics are the central nervous system and the heart. When local anesthetics reach the brain, they tend to block inhibitory nerve pathways, and this leads to excitement of nerves that otherwise should be quiet, so patients tend to sense things that aren't there. For example, perioral numbness can occur. Patients may report a metallic taste. Other more general symptoms can also occur. These are things like mental status changes or anxiety, muscle twitching, or rarely seizures. Any of these type of symptoms in a patient who just received a local anesthetic should raise concern for systemic toxicity. In the heart, systemic administration of local anesthetics can have variable effects. Initially, most patients develop tachycardia and hypertension, but this can progress and become bradycardia and hypotension as the toxicity gets worse. In severe cases, patients can develop ventricular arrhythmias or asystole. And of all the local anesthetics, bupivacaine is the most cardiotoxic. In the emergency medicine section in the video on toxicology, I talk about methemoglobinemia. This condition can be triggered by a number of drugs, and one of the groups of drugs that can trigger methemoglobinemia are the local anesthetics. Most iron in hemoglobin is usually in the 2+ form, but in methemoglobinemia, a large amount of iron in hemoglobin becomes 3+, and when this happens, hemoglobin cannot bind oxygen. This leads to dyspnea in the patient that does not improve with oxygen administration. A classic finding is the presence of chocolate brown blood, and there are a number of drugs that can cause acquired methemoglobinemia, but one of the classic groups of drugs are the local anesthetics. Others are nitric oxide and dapsone. And the treatment for methemoglobinemia is with a drug called methylene blue, which converts iron back into the 2+ form, and I talk about this in much more detail in the video on toxicology. Sometimes local anesthetics are given together with epinephrine, and the idea here is that epinephrine causes vasoconstriction, so there will be less bleeding and also less washout of the drug for more local effect. So for example, if you're suturing a wound in the skin that might bleed when you apply stitches, you can use a local anesthetic with epinephrine, and the epinephrine will minimize the amount of blood loss. So one place you'll see local anesthetics used a lot is for injection under the skin to numb the skin when patients need a skin incision or a suture or something like that. But another major use of local anesthetics is in spinal and epidural anesthesia. This is a type of anesthesia where a needle or catheter is inserted for injection of a local anesthetic. In spinal anesthesia, the needle or catheter is inserted into the subarachnoid space so that you inject a local anesthetic into the cerebrospinal fluid. This is referred to as an intrathecal injection. Any intrathecal injection is into the subarachnoid space. Epidural anesthesia is somewhat similar, but this is an injection into the epidural space. And the idea behind both spinal and epidural anesthesia is to provide the patient an absence of pain sensation below the waist so that the patient can have surgery but remain conscious without having to be put to sleep by a general anesthetic. The most commonly used drug in spinal and epidural anesthesia is the local anesthetic bupivacaine. It's often given together with other drugs for analgesia, things like fentanyl or morphine. And the idea is to inject the local anesthetic into the lower spine and have it travel downwards to anesthetize the lower body. And so therefore spinal and epidural anesthesia are used in situations where you want to allow the patient to remain conscious, but you need to perform surgery or other procedures on the lower body. So you can see spinal and epidural anesthesia used in lower abdominal surgery and lower extremity surgery. It's commonly used in OBGYN surgery. Most C-sections are done under spinal and epidural anesthesia. And then finally, women giving childbirth by vaginal delivery often receive spinal or epidural anesthesia to try and provide pain relief as they deliver the baby. When you administer spinal anesthesia, like I said before, the anesthetic agent will go into the subarachnoid space and enter the cerebrospinal fluid. This is usually done as a single injection of medication, and it provides a very rapid onset of block. An epidural is usually a continuous infusion, and this allows prolonged sensory block. And sometimes a combined spinal epidural procedure is done, where an initial spinal injection is made for a quick nerve block, followed by placement of an epidural catheter for continuous infusion of a local anesthetic. And this is a picture of an anesthesiologist accessing the lower spine. The patient is draped here and bent forward, and the anesthesiologist can insert the needle either into the subarachnoid or epidural space. Let's talk about some of the adverse effects of spinal and epidural anesthesia. One of the most common adverse effects is transient neurologic symptoms. This refers to mild pain or paresthesias in the buttocks and lower extremities that occurs hours after having spinal anesthesia. The neural exam will be normal, and that's very important. If it's not normal, that suggests something else may be going on. The etiology of these transient symptoms is unclear, but they usually resolve if the patient ambulates or takes NSAIDs, and they're almost always gone within a few days. Hypotension can occur from spinal or epidural anesthesia if there's inhibition of sympathetic nerves, leading to vasodilation. And then lastly, we talked earlier about systemic toxicity of local anesthetics. This can happen in spinal and epidural anesthesia if there's an accidental injection of a very high volume of a local anesthetic, or if there's injection into an epidural vein. Another potential complication of spinal and epidural anesthesia is infection. Anytime you introduce a foreign body like a needle or a catheter into the spinal canal, you can potentially allow bacteria to gain entry into the spinal canal. So first of all, this can cause meningitis. It can also cause formation of a spinal epidural abscess. The classic symptoms of a spinal epidural abscess are back pain that's worse when you palpate over the area of the abscess, also fever and neurologic deficits. Now, having said all this, spinal epidural abscesses are famous for being subtle, so in any patient who's recently had spinal or epidural anesthesia, if they develop new back pain or fever, you have to have a high index of suspicion for an abscess. The diagnosis of a spinal epidural abscess is made through MRI with gadolinium contrast enhancement, and the treatment usually involves antibiotics and surgical drainage. The antibiotics need to cover MRSA, strep, and gram-negative rods, so usually vancomycin and ceftriaxone are used initially until cultures tell you what bacteria are involved. A high spinal is a term used to refer to a serious consequence of spinal or epidural anesthesia. This refers to the spread of the anesthetic effect above T4. So normally you insert the drug in the lower thoracic region and it anesthetizes structures downstream from the injection site. But if you lose nerve function up in the higher thoracic region, that's called a high spinal. And what you will see are effects of losing nerve function in the sympathetic, sensory, and motor nerves of the upper thoracic region. Some of these nerves go to the heart, so you can see bradycardia and hypotension. Other nerves go to the diaphragm, so you can see dyspnea from diaphragmatic paralysis. Patients can also develop difficulty swallowing or speaking. This can occur with a spinal or epidural anesthesia. It's usually caused by giving too much anesthetic or by improper needle or catheter position. And then a total spinal is a severe form of a high spinal. This refers to intracranial spread of local anesthetic effects. This can cause loss of consciousness. This is basically the worst form you can have of a high spinal. Another complication of spinal and epidural anesthesia that you should be familiar with is a low pressure headache, also known as a postdural puncture headache. This type of headache is called a low pressure headache because it's associated with a fall in CSF pressure that's believed to be caused by CSF leak from a dural puncture. Anytime you put a needle or a catheter near the meninges and the spinal cord, when you remove that device, there can be a hole left behind that can allow CSF to leak out. And if that happens, that's believed to be what causes the low pressure headache. And so if you understand that, it's easy to understand that these types of headaches are common after a lumbar puncture. They're also common after spinal or epidural anesthesia. And the classic feature of a low pressure headache is what's known as a postural headache. This is a headache that is improved with lying flat and worse when sitting up. If this happens in a patient who just had one of these procedures, that's a classic presentation of a low pressure headache. The diagnosis is clinical. It's made by identifying features of a postural headache in a patient who just had a procedure involving the spinal column. And the treatment is with NSAIDs or with something known as an epidural blood patch. With an epidural blood patch, you take a small amount of venous blood from a peripheral vein and you infuse it into the epidural space. And the idea is that it will form a clot over any CSF leaks in the dura. And when this is done in appropriately selected patients, it can provide immediate symptom relief. Hopefully you get to see this on your clinical rotations, but the relief is very dramatic. The headache can instantly go away. And the idea is that there's CSF leaking into the epidural space, and so when you inject blood in there, it will form a clot, and that will stop the CSF leak. I'll finish with one slide on regional anesthesia. You should just be familiar with these forms of anesthesia in case they come up on your rotations. The first one is a peripheral nerve block. This is used for procedures on the upper or lower extremities, meaning the arms or the legs. The idea is that you identify a specific nerve or plexus of nerves using either ultrasound or a nerve stimulator, and then you inject local anesthetic directly onto the nerve. So this can be used to anesthetize an arm or a leg for a procedure on one of the extremities. Intravenous regional anesthesia is an alternative to a peripheral nerve block for short procedures, usually less than 1 hour in total duration. It's usually done for hand or forearm surgeries, like, for example, a carpal tunnel release. And the idea is that you apply a tourniquet to the upper arm to limit blood return from the hand, and then you inject a local anesthetic into an intravenous catheter in the hand, and this will anesthetize the hand or forearm, and this can be done for a very short procedure that involves the hand or forearm. And that concludes our module on local and regional anesthesia.